Good morning, and welcome to Building a Strong Foundation for Dementia Care. Today, we are here to learn about young onset dementia. My name is Susan, and I am the Provincial Coordinator of Education at the Alzheimer's Society of British Columbia. The Alzheimer's Society of British Columbia is the only province-wide organization dedicated to supporting people living with dementia, people who are care partners, and you, healthcare providers. So we're really pleased to see you today. On our agenda, we will review the diseases that lead to young onset dementia. We're going to meet Elaine and reflect upon the experience of young onset dementia through her eyes. We'll consider some strategies and approaches to care. And we will definitely locate online resources for further learning. We have a fantastic website to share with you and a helpline to answer all your questions. Before we dive in, I'd like to pause and ask you just to write down 3 words. 3 words to describe your impression or your understanding of young onset dementia. And throughout this video, I'm going to ask you to go back to the 3 words and check in to see if they still are accurate for you. So 3 words that you would use to describe young onset dementia. Let's start with some facts. Young onset dementia is an umbrella term. So it refers to different types of brain diseases. You can compare it to the word cancer. Cancer is an umbrella term as well, and it refers to all different types of cancers. Same kind of thing. Symptoms for young onset dementia occur in people from age 18 to 64. It's rare. And according to 2020 stats in Canada, 28,000 people are living with young onset dementia, and it's growing. By 2050, we expect that number to increase to 40,000 people. The symptoms are different for each person and each type of dementia. So we're going to share a checklist with you today, and SafeCare is providing this as a resource attached to this video that describes multiple changes that can occur with young onset dementia. We know that there are about 50 different diseases and disorders associated with young onset, and that they each affect the brain differently, so the symptoms will vary. Today, our focus is on young onset Alzheimer's disease. Now, most people with Alzheimer's disease are over the age of 65. However, young onset Alzheimer's disease does occur in younger people. Now, young onset Alzheimer's is the most common form of young onset dementia. And researchers don't know yet why some people get the disease at such a young age. What they do understand is that there can be a genetic link, which in some cases is called familial Alzheimer's disease. Having a parent or a grandparent with young onset Alzheimer's increases the risk of developing young onset. A very small number of people with young onset Alzheimer's carry a genetic mutation. It's very rare. There's fewer than 1 in 100 cases of Alzheimer's disease will be the result of a genetic mutation. Sometimes family members with a history of young onset Alzheimer's disease choose to receive genetic testing. It's a big decision. It takes a lot of thought, but there is such a thing as genetic counseling to help these people. Not everybody wants this information, and the information can be devastating and kind of scary, and so there's counseling to support. Young onset Alzheimer's disease, our spokesperson today is called Elaine. Now, Elaine is living with young onset. She was diagnosed 5 years prior to this video. So keep that in mind when you see how capable she is. She's been living with dementia for 5 years when she makes this film. I'm going to ask you at the end of the video how you think she's doing. But before we jump in, I'd like to share Elaine's obituary. She passed away peacefully on April the 18th, 2013 at Little Mountain Place. Now, Elaine was diagnosed with young onset Alzheimer's at the age of 47. She had a strong will to live and live life to the fullest, traveling the world for as long as she was able. She was strong, intelligent, and beautiful. A longtime employee of BC Tel, which is now TELUS, Elaine was the first person diagnosed with Alzheimer's to be on the board of directors for the Alzheimer's Society of British Columbia. A strong advocate for Alzheimer's awareness, she was part of the Ascent for Alzheimer's. This is a huge fundraising event for which she climbed Mount Kilimanjaro. She will be missed by Team Elaine and her family. So often when we think about dementia, we think about the losses, and there are losses. But when we get to know Elaine, we see there are also incredible moments of accomplishment and courage and strength. Let's dive into the video.
When I get up in the morning, I have to look in the book to determine what I'm going to do for the day. At noon, I'll look in the book and see what am I doing for the rest of the day.
55-year-old Elaine Wright has Alzheimer's disease, the most common of the many forms of dementia.
If somebody asks me a question, what happened with this? I have to go back in the book and see what I did on that day or what I did about this situation. I'm going to figure out make sure I got the right day on it, on the market. And initially, yes, you can be frustrated by that. But the upside of it is, okay, I can deal with this. It doesn't matter if I forget things, as long as I have a backup. Thanks, bye. Calling me back for a second flu shot. Oh, really?
Elaine can still look after her own practical needs, but likes having her niece Wendy live with her.
Having people around the house and activity is really interesting. You're involved in other people's lives. You're not alone.
I am very fearful for my aunt about this disease. It's a horrible disease. I think it's probably worse than cancer, I think, the end effect, because you have a great physical body and just a mind that doesn't cooperate.
This is The Handmaid's Tale. I loved Margaret Atwood. I had one of those time frames where I read her all the time. Well, I had a life in books. Now I have a life in magazines and newspapers. A deep, dark novel is more than I can manage because I can't retain the information that I've already read. So I can read on Monday morning. Monday afternoon I'll pick up the book again and not be able to recall the major themes of what I saw in the morning. Knitting in itself, once I figured out, what I'm doing, won't be an issue. It's keeping track of the stitches when you use a pattern.
Elaine used to be an avid knitter, but she's forgotten how and is determined to learn how to do it again.
It has been frustrating because it's not just, it's a visual thing, it's a tactical thing as well. So what was once very easy to do is hard. But I'm going to keep working at it.
Elaine's problems started back in the fall of 2001. She was 47 years old, a single mom with a teenage son.
Prior to my diagnosis, I was working at TELUS, and I ran a small technical writing department with several people working for me. And I began to notice that I was less effective or productive in my work. This particular day that really hit me was a bright sunny day. The light was streaming into the room and I just sort of faded away, like I just couldn't really get connected to anything.
That fade out sent Elaine hurrying to her doctor, who quickly zeroed in on Alzheimer's disease, and because of Elaine's young age, referred her to a neurologist at the University of British Columbia.
I think my experience of that time was fog for me. apparently I wasn't able to grasp what he was telling me, and he had said that I have Alzheimer's, or I likely have Alzheimer's.
Hey, so let's just stop here and think about that video and what happened. And I'd like to know, what is your initial reaction to Elaine's story? What surprised you about Elaine? And when you look back at the 3 words you wrote at the beginning of this presentation about how you would describe young onset dementia, do those words fit for Elaine? And I think it's really important to ask the question, so what is Elaine doing well? Because care should enable her as much as possible to keep doing things well. So if she already has a skill set, care should support that. We're going to watch a video now and just learn a little bit more about what is happening inside Elaine's brain. And we're also going to see Elaine take a test at the UBC clinic. So here we go.
So I'm going to start by showing a normal brain as reference.
Dr. Ian McKenzie studies the effect of dementia on the brain.
And looking at the front surface of the brain here, what we're looking at are the folds in the cerebral gray matter, separated by these rather narrow valleys. You can see that the tissue is really very much pushed up against itself, so that there's very little space in between the individual gyri. If we compare that to an individual who had suffered from dementia for about 8 years before they died, the amount of space between the gyri, the sulci, has expanded, and this simply reflects tissue loss.
This tissue loss may eventually affect all brain functions. So doctors know what's happening to Elaine's brain, they just don't know how fast.
Let me ask you, what is today's date?
I don't know.
Okay. What am I holding?
A pen.
Elaine begins with an assessment of her sense of time and place, her short-term memory, and her ability to express herself.
Now I'm going to say 3 words. I want you to listen to all 3 of them. I want you to repeat them after me when I have said them, and then I want you to commit them to memory, because I will ask you about them later.
Right.
All right? The words are shirt, brown, honesty. Can you repeat them?
Shirt, brown, honesty.
Good. I would like you to use this blank part of the page to draw a big circle. Inside the circle, I would like you to draw a clock face with all the numbers corresponding to the hours. Okay, now I'd like you to set the time at 10 past 11 on this clock. Okay. Back to the 3 words. What were those? What were those 3 words?
Honesty,
Yeah,
and the other 2 are gone.
they're gone. But let's try and bring them back.
Yeah.
I'm going to give you a hint.
Okay.
1 word was something to wear. Do you remember what it
Oh,
was?
shirt.
Very good. So they're there.
They're there. They,
Okay.
Yeah.
The other word was a color. What was that?
Black.
Okay, I'm gonna say 3 words and you're gonna pick out the one you think it was.
Okay.
Here are the 3 color words. Blue, black, or brown. Which one was it?
Well, they said it wasn't black.
Right.
So it's either brown or... I forget what the other one was. Oh,
Blue.
Brown or blue?
Yes.
Oh, blue.
Okay.
Good.
I'm gonna tell you which the correct one was. It was brown, actually.
Oh.
Okay?
Okay.
All right.
Okay.
Is look
Next,
straight
a
ahead.
neurological exam.
Look straight over in the distance. And I'm going to have a quick peek at the back of your eye here. We're looking for whether there's a movement disorder, whether there's a change in walking, whether there's any type of just cross your arms here, difficulty using limbs, to give us an idea of where in the brain the problems reside. I'm going to just test your sensation now with a very light toothpick.
One of the reasons Elaine is still able to live on her own is because she was diagnosed early.
It's not an automatic death sentence. The difficulty is that most patients who suffer from dementia are diagnosed very late. I mean, even the grandchildren in the house know that something's wrong with their grandmother. So when you take them to the doctor, you've lost half of your brain capacity by then. Whereas if it's diagnosed early, then it gives you an opportunity to have control over the disease, to manage it.
Okay, let's talk a little bit about diagnosis because, as that physician just stated, that timely diagnosis makes a big difference in the world of a person living with young onset dementia. So Elaine was very, very fortunate that her physician, her GP, recognized the symptoms and referred her to a specialist. Research tells us that it can take over 4 years longer to get a diagnosis of young onset compared to older people who live with dementia. So those who develop the symptoms at or after age 65. So please do check our resources for the checklist for young onset. It is a great tool if you know somebody who's worried, who might want to talk to their doctor. They can take in that checklist and use it as a tool to open the discussion. So here are some of the challenges. There are symptoms such as mood changes, forgetfulness, or changes in the ability to concentrate and work, and changes in the ability to problem solve. Now, all these changes can be attributed to other life situations. They could be attributed to stress or menopause, depression, or even mental health issues. And they are also symptoms of young onset dementia. Healthcare providers may not be trained to spot the signs and associate them with dementia. Elaine shows us in the video, in the first one, that she has developed a lifestyle such as having her niece live with her. She's developed tools such as her notebooks and diaries that help her manage her daily life. She already has a team of medical professionals who monitor and test and ensure she has access to medications that can help. So this kind of planning, this level of support, is enabling Elaine to live well with dementia as well as she can. She gets to decide whether she wants to share her diagnosis with her family. She gets to decide if she wants to try medications and what she wants to do as her dementia progresses. She's in control. Her timely diagnosis has given her that control. So that's really important. A delayed diagnosis would have robbed Elaine of so much of this decision-making power. Let's consider some of the unique things that happen and that are associated with young onset for the person who receives the diagnosis and the people around that person. So in our video of Elaine, we see a woman who's focusing on what she can do. However, there was a time when Elaine was just getting diagnosed that she was very frightened, and she called this a dirty, ugly disease. And those were her exact words. Well, she, of course, would have had concerns, and we've made a list here. So the first one is, well, the emotional impact of this diagnosis. For a person diagnosed, the spouse, the children, the niece, the nephews, well, they might have fear of the unknown. There might be anger or resentment at the massive shift in daily life. And also a lot of emotions around how the children or younger members of the family are going to experience changes, such as they might actually be contributing to caregiving. The spouse will often be grieving while they watch the dementia progress. The spouse may be concerned about becoming a care partner, worried about the future. And a person living with dementia will often express that they don't want to become a burden. So there are strong emotions attached to this diagnosis. Massive changes will occur in relationships as a result of young onset. So the whole family dynamic will change. The family will need to be able to adjust as the dementia progresses because there's constant change. The spousal relationship will change, intimacy and sexuality will change. Then there's keeping friends and losing friends, which we know happens when a person is living with dementia. Questions about identity will arise. Who am I? Who will I become? And what is my purpose now? Am I losing myself? So I'm no longer the dad who drives the kids to soccer. I'm no longer the mom who takes care of the family budget and organizes the vacation. So who am I? I'm not a parent anymore. Who am I? And do I have any value to my family now? Young onset brings unique concerns to changes in responsibility and changes in finances. This could be a very scary situation because people may be wondering how they're going to cope. They may be paying off a mortgage, paying off a car. And then, of course, there's just regular expenses and family expenses. Can they work? Are there financial supports available to them to cope? Young onset people aren't senior citizens. They're younger. They don't qualify for pensions, but well, would they qualify for disability? Do they have savings in the bank? Like, what's available to them? How are they going to pay their bills? And of course, there's questions around support. Well, who's going to help me and my family navigate this disease? And how do I know where to go and what to do? Many people have never heard of young onset dementia. They don't have a clue what the first step might be, and they don't know what to expect or where they can find reliable information. Many people diagnosed with young onset dementia want to meet other people like them. They want to learn from those people and get some peer support. Well, they might not know where to go to get that. I think it's fair to say that a diagnosis of young onset dementia can create massive upheaval for the person who's receiving the diagnosis, but all those people around that person as well. And you are probably noticing this in your role as a healthcare provider. So how does that affect our approach to care? Well, we've looked at Elaine. We've got a sense of what life is like through her eyes and her experiences. And we've looked at the impact of a diagnosis. So let's start with Elaine's independence. It's pretty clear that Elaine is in charge of her life and that her care should respect her wishes to be as independent as possible. A strength-based approach to care focuses on Elaine's abilities rather than her deficits. And this approach ensures that Elaine remains involved in her care and can make choices. And choices are very important. So she can make choices that impact her health and well-being. It treats her as a partner in care, and it shifts the focus from delivering a service to fostering a partnership where Elaine is empowered to do as much as she possibly can. Now, this approach requires an understanding of Elaine's current capabilities, so what she manages well as what challenges are emerging. And it's also important to understand how Elaine prefers the care to support her. She will probably have opinions about what she wants and how she wants it organized. So it means asking a lot of questions, developing trust, having really open conversations, doing a lot of listening, and observing. This is what we call a partnership from care. And as I mentioned before, it's a shift. It's a shift from I'm here to deliver care or give care to actually I am here to empower you to do as much as possible and support your care. So in this shift to a strengths-based approach, we're really honoring Elaine's autonomy, and we're doing everything we can to maintain her dignity and to reinforce her role as the person who's managing her health and her life. One of Elaine's strengths is her ability to develop and use systems to keep her organized, and we saw this in the first clip. So let's take an example of booking appointments with Elaine for a weekly shower. We know she maintains a detailed diary, so take the time to sit down with her so she can consult her diary, reconfirm that appointment, encourage her to make her own notes about buying shampoo, preparing towels, having the bathroom ready, whatever's required. So empowering Elaine as an active partner in the care planning process. So this means that you need to know about Elaine's system, and then you start to incorporate your work into her system. Maybe offering a reminder call, a text, or an email could help. Just helping Elaine feel prepared and involved. And then offering support with Elaine in the lead, ensuring that she has the opportunity to communicate to you what kind of assistance she needs and how you can best assist. Now, we work with people who are living with dementia at the Alzheimer's Society of BC. It is part of our vision to incorporate as many of their voices as possible. And so we've learned a lot about the use of tools and technology and how great tools and technology can be for people living with dementia. So let's take a look at this list. Starting with smartphones. Well, smartphones have all kinds of handy apps. There's the text-to-speech, there's large print options, there's dictation technology, alarms, object detection, GPS, and more. They are used tremendously by people living with dementia. There's also digital calendars that can set reminders and help with scheduling. Text messages are a written record of a conversation, and they can help someone who's living with short-term memory loss. They can go back to their texts. Alexa, Google Home, and Siri can also provide reminders, answer questions, play music, find information about the community events, help support routines, store phone numbers, call people, manage contact information, and a million other things. Tracking devices are popular with care partners who are concerned about a person getting lost. We get a lot of phone calls from care partners about tracking devices, but they're also appreciated and used by people who are living with young onset dementia because they empower them to go out and enjoy themselves. So the tracking device enables a person to go out for the day and know that they have a safety plan. They have a backup plan if they get lost. It's one step closer to being more independent. Aphasia apps are something that some of you are probably already using, and we have provided a link to a website about these apps, and we've given that link to Safe Care. Now, these apps aid in communication. They involve pictures and text so that if somebody's having problem speaking, sharing messaging, or even understanding your messaging, this app can help. And finally, there is actually a website of recommended apps for people living with dementia. And these are fun apps. They're cognitive games that have been reviewed scientifically by a team of researchers. They're games that are fun, but they're also games that are brain exercises. And that's called the Act2 Dementia website. So we're going to go back to Elaine just one more time. She's going to share with us about her routine and the power of exercise.
Okay, give me 5. That's the one. Yeah, good boy. That's the one. There you go. Before I got on the meds, I would just not be able to connect, not to focus. I would just be unable to activate myself to keep on moving. So I'm now engaged again. I'm able to do the things I want to do with people and get out. I'm not the same as I was before. Oh, Homer, look who's over there. It's a doggy. Well, it's really, really important to stay physically active for me because it reduces stress, and stress is a really bad thing. It aggravates the disease and certainly eats up a lot of time that we don't have.
Okay, so Elaine mentioned two things there. She mentioned meds, and medications are available. They're not cures for dementia, but they do support the brain to work better. And as Elaine described there, they really helped her. And the second thing she mentioned was the power of exercise and why she needs exercise to reduce her stress level. So keeping active, keeping moving is a key part of Elaine's routine. So now we know a little bit about Elaine. We're going to just briefly summarize what we know about her, and then we're going to shift into a case study. So cognitively, we know Elaine is thinking, she's making decisions, she's problem solving, and she's managing her life. We know that she enjoys reading, although it's a different kind of reading. And we know that she enjoys knitting, although it's a different kind of knitting, probably more simple. We also know that she's very willing to challenge herself because knitting's not easy. She's having to relearn it, and she's willing to take on that challenge. We know that Elaine wants connection to people. She enjoys having her niece there. She wants to have other people's lives integrated into her life. And we know that she likes to walk and she loves pets and she is managing stress. She realizes that stress is not good for her brain. So these are all important things that we need to know about a person before we start to provide care. Let's move on to our case study. So how do we plan for person-centered care? We're going to take on a case study for long-term care today. Now, during my time working in long-term care and supporting people living with dementia in that environment, I observed the need for increased planning and strategies to support people living with young onset dementia. And the story I will share with you today is about Amelia. So Amelia is the person on the right. And as you can see, Amelia worked as a nurse. We're going to look at what her values are, what's important to her. We're going to look at her strengths and what brings her happiness. And from that point, we're going to think about care. So first of all, Amelia's living with young onset. She had a nursing career for over 25 years. She's mobile, energetic. There are no changes to communication, so she has a lot in common with Elaine. Amelia needs to work. Her leisure and hobbies, or the leisure and hobbies that are offered in long-term care, are not interesting to Amelia. She does not want to participate. She wants to care for the residents around her in the unit, so she wants to do a job. She still thinks she's a nurse. Now, Amelia is young. She does not need or want downtime. She wants to be busy all day, every day, and she's got the energy to do it. Her health and well-being are linked to productivity. This is who she is. This is who she's always been. It's been her lifelong strength, her energy and commitment to helping others. Her work as a nurse has been and is a primary form of identity and pride. So as the youngest person in the unit, she looks around and she sees herself as somebody who is there to help the elderly people around her. And she feels happy when she's helping. She feels happy when she's busy. We're going to start with an approach that will usually backfire, and it is called the reality orientation approach. And I'm going to share this approach with you now. If I said to Amelia, no, Amelia, please don't help those people, or please don't try and do that. You are no longer a nurse. This is a care home. You live here now. You are a resident and you have dementia. So that's reality orientation. I just want to pause and think, how do you think that would go? Would that reality orientation of explaining to Amelia what is happening in the here and now, would that actually help her? Well, it is a correction. And so we're trying to correct the way Amelia is thinking with that approach. And that type of correction can lead to confusion. It can also lead to conflict. And we don't want to go to conflict. We don't want to stress that brain. That correction is also an attack on Amelia's identity because she's very clear who she is and why she's there. And we don't want to attack that identity. It brings her happiness. It contributes to her health and her well-being. So rather than reducing her self-esteem by correcting her and stopping her, we need to get a little bit creative here. We have to find a way to keep her involved, keep her happy, keep her feeling good, keep that self-esteem high, but also keep her safe. Let's look at some options. So we looked at the correction on the left. You're not a nurse, you're no longer working, you live in a care home now is a correction. And we know there are great risks associated with that specific approach. Another one would be, please don't do that. You're not a staff member and it is not safe. And indeed, that might be the truth in the moment, but it is still a correction and it is still a very risky and demoralizing approach for someone living with young onset dementia. Let's consider a connection piece here. Now, with connection, we're not trying to change Amelia's mind. We're validating that she is in a different reality. We're allowing her reality to be the boss reality. We know that she has dementia. We know that the dementia is changing her link to time and place. It perhaps is contributing disorientation. And we're going to work with that. So in my experience, it's better to be prepared and have a plan. We need to build a routine for a person like Amelia rather than constantly having to come up with creative ideas on the spot. A daily routine, one that everybody on the team knows about, is ideal. Young onset is going to bring challenges into the care home environment. You have a young, energetic person who wants to be busy. So get that social history. Learn as much as you can about the person, like we did with Elaine today. Get that social history. Make sure the whole team is aware of that social history and start to prepare. Brainstorm ideas and ensure that all the departments are involved in the learning and planning. Elaine's going to move all around that care home. Everybody needs to be on the same page. This is real teamwork. No one team should be responsible for Amelia's health, well-being, and quality of life and care, especially because she's a person who does not want to attend programs. She wants to work. So we need the front desk staff on board, the dietary staff, the care staff, the rec staff, the nurses, probably OT, PT, management, and more. Let's consider some connection possibilities here. One connection would be, oh, it's great to see you, Amelia. We have lots of work to complete today. Now, if you've done your homework and you've got the routine planned, and now you can use that connection to shift Amelia into a job that you've prepared. She can do this job in her unit. She can do her job in the dining room, in the lounge, in the front desk, wherever her job is, she can transition to that job. Another example of connection is, thank you for being so helpful. Santa, the nurse, is looking for you. What's on your work schedule today? Well, what is on her work schedule? Have you taken the time to actually prepare a work schedule? Maybe Amelia has a great big whiteboard in her room or something posted on her door every day with Amelia's work schedule, so she knows what to do. Maybe she carries it in her pocket. It depends on what works for her, but she does need a schedule ahead of time to keep her on track and keep her engaged. And this is in the best interest of staff because, as I mentioned, coming up with constant validation, connection, and redirection is a lot of work. Whereas if you have planned and prepared ahead of time and the whole team is on board with the routine, you can save yourself a lot of time and energy. In our live presentation, we stopped here for discussion and questions. I'm going to move on and just summarize what we've learned today and share some information about the Alzheimer's Society of British Columbia. I really hope we've increased your knowledge of young onset dementia today. If you go back to the 3 words you wrote down at the beginning of this presentation, take a look at those now. And I'm just wondering perhaps if we've changed your perceptions, and I really hope we have. We reflected on Elaine's perspective of lived experience, so we kind of got an insider view of what it's like to live with young onset dementia. We recognize the importance of timely diagnosis and how that empowered Elaine. And we also considered a person-centered, strength-based approach to care using Amelia as our case study. We hope you stay in touch. The Alzheimer's Society of British Columbia is available to you in many ways. I'd recommend writing down the phone number for our dementia helpline. It's 1-800-936-6033. Our helpline is available to anybody who has questions about dementia or cognitive change, not just Alzheimer's disease, but any kind of dementia. We're here for you. We especially encourage you as a healthcare provider to call us and find out about our resources. We can connect you on the website so you can do your own reading. We can send you stuff in an email or when the Canada Post strikes over, by mail. Please stay in touch and please use us. We want to be helpful to all healthcare providers and help you support people living with dementia. That is the end of my slideshow today. Thank you so much for joining us. It's a pleasure to have you here.